Welcome back, everyone. I would like to introduce our next speaker. It's Dr. Joshua Kurtz. Dr. Kurtz is an assistant professor of pediatrics at the University of Louisville and a pediatric and adult congenital interventional cardiologist at Norton Children's Hospital. Dr. Kurtz completed his medical education at the State University of New York at Buffalo, followed by a residency in pediatrics at Miami Children's Hospital. He further specialized with fellowships in pediatric cardiology at the Medical University of South Carolina and interventional cardiology at the University of Washington and Seattle Children's Hospital. Currently, he serves as the program director for the Pediatric Cardiology Fellowship at the University of Louisville and clinical lead for the cardiology block of human systems in health and disease for second-year medical students. Welcome, Dr. Kurtz.
Thank you so much for having me, and thanks for allowing me to speak today. As Dr. Perta said, I'm Josh Kurtz. I'm one of the pediatric and adult congenital interventional cardiologists, and I'm going to be speaking today about advances in transcatheter pulmonary valve replacement, expanding treatment options for a complex population. I have no disclosures or conflicts of interest. After this session, you should be able to determine the options for transcatheter pulmonary valve replacement, identify who is a candidate for transcatheter pulmonary valve replacement, and describe the risks and complications of transcatheter pulmonary valve replacement. I'll also put a note here. I apologize. I didn't realize today was all live stream. So there are a couple of slides with kind of questions to the audience. So if you don't mind putting those in the chat, we'll see how that goes versus people just yelling them out. So I just want to start and make a note that we'll focus on, and I think this was not the updated one. We'll focus on those valves that are currently available in the United States. I apologize. I think this is not the most updated version. So there were supposed to be pictures of the Melody and Sapien there, not the words. But if you can see here, this is below are the pictures of the Melody valve and the Altera pre-stent, which are available in the US as well as the Melody and Sapien valves. We'll not focus on these valves, though they are used outside of the US, but just so everyone is aware that there are a number of other transcatheter pulmonary valves that just are not currently used. I think to start this, we have to kind of understand how we got here. And so the first transcatheter pulmonary valve, and actually the first transcatheter valve, was first done by Philippe Bonhoeffer in France in 2000. This was a hand-sewn bovine jugular vein valve into a platinum iridium stent. And while the initial prototype that he used in his first implant is not what it looks like today, this is the valve that eventually became the Melody valve. In 2006, Melody valve officially was CE marked in Europe, and by 2010 had full FDA approval here in the US. Shortly after this time, the Edwards Sapien valve, which was initially used as a TAVR valve, was starting to be used in the pulmonary position. In 2015, the Harmony valve, so our first self-expanding valve, began its early feasibility trials, followed by actual approval of the Sapien valve for use in the pulmonary position. And then just a few years ago, the Harmony valve was given FDA approval and is now in full use in the United States. And so you can see that the use of transcatheter valves have grown very rapidly, but have only been around for about 25 years. And so I think before we get into kind of what we have available and how we use them, we really have to understand who actually needs a transcatheter pulmonary valve. And so we'll see how this works with the chat, but if anyone can kind of throw in the chat, what are some of the indications they think of for transcatheter pulmonary valve replacement, or who might need one?
If you can actually put your answers in the Q&A box at the bottom of your screen. If you hover over the bottom of your screen, sort of to the right, there is a question mark in a little thought bubble, and it says Q&A underneath.
You pull up the Q&A, yeah. Yeah, we get both that way. I can kind of look at both. I'll just give it 30 seconds. We'll go on. Oh, there we go. All right, so we got one pulmonary valve stenosis. Cardiomyopathies. So yeah, not too many cardiomyopathies need a replacement of the valve. Um, That's so, yep. So most of our answers are looking around stenosis, and so I think those are great answers, and I'll pull that up in a second. But here are sort of the guidelines that are used in general for who needs a pulmonary valve replacement. And the first thing I want to highlight is you notice that these are three major societies, and all three do have slightly different criteria. Though I'll kind of highlight the similarities because despite the fact that the AHA, ACC, the European Society of Cardiology, and the Canadian Cardiovascular Society all technically have different indications, they're very similar. So the first thing is moderate or significant pulmonary regurgitation. So that is kind of the first thing. But not only do you have to have that, it's that and something else. So regurgitation and symptoms or objectively reduced exercise capacity. Regurgitation and a large RV. And while the definition of RV enlargement is slightly different and other papers have used different definitions, all three of these societies do kind of define it as greater than 160 milliliters per meter squared by MRI. Or significant regurgitation and RV systolic dysfunction. And so I think while there's some slight differences, these are generally accepted as the reasons for this. I will also make a note, especially around the RV enlargement, that these are the guidelines for patients with tetralogy of Fallot, and therefore it may not be fully transferable to other conditions. I did not highlight on that last slide what everyone had mentioned, or most people had mentioned in the chat, which was the pulmonary valve stenosis. And I think that's because while the recommendations here do include it as regurgitation and significant obstruction, I think most of us would consider that an indication independent of pulmonary regurgitation. That if you were to have significant RV outflow tract obstruction, you would address this, and most times addressing this would require that you now would require now placing a valve because you would create unrestricted pulmonary regurgitation. But that really begs the question, okay, now that we know who needs the valve, can everybody get a transcatheter valve? And so we'll see how this one works this time. But what do people think about as those who are eligible? And I think this is the much more nebulous question. Yeah, no, just give me like 30 seconds. So yeah, so I apologize for some of that, but we'll just kind of move on. So so this is really kind of again, I think a general consensus, but there's no true kind of guideline as to who is eligible. And so the Melody valve was initially created and indicated for dysfunctional right ventricular outflow tracts with an RV to PA conduit. As time went on, this was able to expand to those with bioprosthetic pulmonary valves, the so-called valve-in-valve. And then as the Edwards Sapien valve became used, because it is a larger valve, there were some native outflow tracts that it could be used in. There was a great diagram that came out a few years ago. I unfortunately just couldn't find the paper with it, so I tried to recreate it here. But if you look at all those with dysfunctional right ventricular outflow tracts, you can have this due to an RV to PA conduit, native outflow, just a dysfunctional native outflow tract, or surgical patch tracts. As we said, the RV to PA conduits are eligible for a transcatheter pulmonary valve. And while there are some native outflow tracts, that number is few. And then the surgical patched outflow tracts, just because of their shape and size, really weren't eligible. Those who had the surgically patched or native outflow tracts and eventually got a surgical bioprosthetic valve are then eligible. But if you look at this, the total patients eligible for a balloon expandable transcatheter valve is only about 15 to 20%. So this still leaves the vast majority of our patients ineligible for transcatheter pulmonary valve replacement. And that's where some of the self-expanding valves came in. These were designed for native and patched outflow tracts. They fit in the large and pyramidal shaped outflow tracts of those with a transannular patch. This is the much greater proportion of those with dysfunctional right ventricular outflow tracts. And the Harmony TPV25, which is the much more common one used, can accommodate outflow tracts up to 38 millimeters. And the Altera pre-stent, in some descriptions, can accommodate outflow tracts up to 42 millimeters. Unfortunately, eligibility is still not 100%, though those who have made it in newer studies to screening, about 60 to 70% are eligible. That's significantly greater than the actually early feasibility trials, which were only about 20 to 30%. So as we've had the new larger, the TPV25, as well as some new eligibility criteria, that has increased greatly. All told, if you include those with those patients eligible for transcatheter or balloon expandable transcatheter valves, you get about 75 to 80% of our patients, or probably about 3/4 of our patients are eligible for a transcatheter valve. For those who are not eligible, there have been some creative ways to still allow a transcatheter pulmonary valve replacement with things such as putting Melody valves in each of the branch pulmonary arteries, or other ways to reduce the size of the right ventricular outflow tract to accommodate a transcatheter valve. One reason that a patient may not be eligible, even with an RV to PA conduit, would be coronary compression. About 5% of patients are ineligible due to this, and it's something that really should be, testing should be done in any procedure prior to a balloon expandable valve. You can see in the pictures here, this is an example of coronary compression. And so despite having a bioprosthetic valve, it should give some protection to the outflow tract. You can see here on the panel on the left, with the balloon not inflated, that there is nice filling of the left coronary artery. You can see the circumflex, as well as its marginal vessels and the LAD. And then the panel on the right with the balloon inflated now, you can see the balloon is touching up right against the LAD with sluggish flow and significantly decreased flow, not seeing the distal branches of the LAD. And so unfortunately, this is a patient who, while otherwise would be a good candidate for a transcatheter valve in terms of size and shape, just is unable to get it due to the risk of coronary injury. So what complications do we have? Well, first is the coronary compression we just discussed. There is some decreased risk in those who undergo the self-expanding valves, because those valves produce significantly less radial force, as well as the idea that they're only trying to fill the space that is already there for the outflow tract, as opposed to trying to expand the size of the outflow tract. Ventricular arrhythmia, and I think that's kind of been one of the big discussions today, has mostly been around arrhythmias, have been found in anywhere from 1/3 to half of valves have found to be have non-sustained ventricular tachycardia at the time of implant. And I think this is really discussing more the self-expanding valves than the balloon expandable valves. Fortunately, sustained arrhythmia in these patients is significantly rare, only about 3 to 5%. And then most of those, even non-sustained arrhythmias, do resolve at midterm follow-up, with only 5 to 14% in the more recent studies having continued non-sustained ventricular tachycardia. While I won't go into too much detail, as I'm not an electrophysiologist, there is some discussion on whether preemptive EP study and ablation is necessary in some of these patients. And I don't think there's any data yet to support this. And I think the jury's still out. But I do know some centers have brought up discussions about performing EP studies in patients who are high risk for arrhythmia after these, especially because sometimes the new valve frame may cover the nidus for where this arrhythmia may come from, and thus making our EP colleagues' job much more difficult trying to get to it. Another risk factor or complication we can see after transcatheter valve is conduit tear. This can be seen in up to as many as 4% of patients. This can be treated in the cath lab with covered stent placement, and again, is much more likely in balloon expandable valves, especially in heavily calcified RV to PA conduits. The panels at the bottom of this slide show you an example of this, with the panel on the left showing a contained tear at the proximal portion of the RV to PA conduit. The middle panel shows a repeat injection after covered stent has been placed, and you can see there's no more filling of that contained tear. And then the last picture on the far right shows an injection after the valve implantation, and now with the covered stent, there's no extravasation of contrast and now competent valve function. Another thing we worry about is device embolization or migration. The risk of this is relatively low at probably 1 to 2%, and I would suspect in the more modern era, this might even be lower than that. And then lastly, a risk of endocarditis, and I'll talk more about that in just a minute. So how have we done? So far, outcomes have been excellent for this. In general, they're comparable to surgical pulmonary valve replacements. And now that we have over a decade of experience, really 2 decades of experience with balloon expandable valves, we found that their freedom from mortality at 10 years is 90+%. There is the concern of increased risk of endocarditis. The good news is most studies show that survival in spite of endocarditis is equivalent. So despite the higher risk of endocarditis, there is not an increased mortality. And that begs the question, though, is the Melody valve an increased risk for endocarditis? There have been some studies that have shown this, though there was a recent study from a multi-institutional study from a number of our colleagues that did compare Melody valve to the Sapien valve as well as surgical pulmonary valves, and did, when comparing for an RV to PA conduit, a placement in an RV to PA conduit, it did show that that difference in increased risk in the Melody valve may be mitigated. And so this may be more a factor of the conduit environment itself, which we know is an increased risk for for endocarditis. And since the Melody valve really is only capable of being placed in a conduit, that may be where that increased risk comes from. So I still think it is something to be mindful in our patients with a Melody valve, but it may be more the conduit environment itself than truly from the valve. While our follow-up for those with self-expanding valves is much more limited, we do have a number of some of the early years of data in these patients. And looking at the 3-year outcomes of those with the Harmony valve, they found 96% freedom from moderate pulmonary regurgitation or greater. And then looking at both Altera pre-stent with the Edwards Sapien valve inside, as well as the Harmony valves, 98% have acceptable hemodynamics function at about 13 months. And I think most importantly, as we discussed earlier, despite all this, there's no new long-term hemodynamically significant ventricular arrhythmias. And so really what's to come? And so as we kind of talked at the beginning, this is an expanding technology for this population. One thing might be just those new valves those valves available outside of the US that I had mentioned. Some of those may become available in the United States, giving us more in our cupboard to use. And then I think we have to talk about, as our adult congenital patients were kids, and would we be able to start really even the work on their transcatheter pulmonary valve work prior to them becoming adults. And so there's a newer surgically implanted valve called the Otis valve that basically the size can be dialed up. And so it can be implanted at whatever size is appropriate for the child, and then is balloon expandable throughout its life. And so it can be expanded to adult size. It's a pretty cool technology, the way the valve frame is shaped and the way the valve leaflets are, so that even with expansion, the valve leaflets continue to work, as well as at smaller sizes, the valve leaflets are still fully capable of working, which that actually is some of the problems with these, with the current valves. They won't work as well if they're not fully expanded. Other options is they're working on transcatheter pulmonary valves that can just be used in smaller patients. The polyvascular valve can be implanted as small as 14 to 16 millimeters and says that it can be expanded again safely, just like the Otis valve, up to adult sizes. And then I think the Iris valve, which I believe was actually created by our former cath lab director here, Mitch Recto. I'm almost sure he was the director here at one point. It can be implanted as small as 12 millimeters and dilated up to 20 millimeters, which is essentially the size of the Melody valve with continued valve function. This can be implanted with as small as a 12 French sheath, which is the same size essentially that we use for many of our ASD occlusions. And so this is something that could be implanted in a smaller child, and if the valve continues to function, dilated up until their adult life. And then I'd be remiss if we didn't talk about kind of our new way of looking at things. And in the past, the goal was really, how do we get this patient fixed now? As our patients are living healthier, longer lives, we no longer have to plan for now, but for the lifetime. And not just this valve, but the next valve and the next valve after that. And so the Mayo Group has shown in a swine model this valve and valve and valve and valve and valve, et cetera, ability. And so they've, on a number of cases, and have actually presented this live at the PICS meeting a few weeks ago, that they can put up to 8 Melody valves inside the Harmony valve without expanding the frame and maintaining internal diameter. And so what I mean by that is the Melody valve has that hourglass shape. And so without expanding past without expanding that middle kind of indented portion any further than the outer frame, they can maintain the internal diameter of the Melody valve. So despite 8 Melody valve implantations, they continue to have the same internal diameter of the valve, which is what the limiting factor of valve and valve replacement really is. That as you increase the valve number, you may decrease the internal diameter, and therefore the valve is no longer large enough for our patient. And so I think if this is possible, this will really kind of change some of our thoughts, the way that we do valve replacement, because hypothetically, even if you got a Melody valve at 25, you would never need another surgically implanted valve for the rest of your life. Also, this is important because where we talk about the coronary compression, that comes from expansion beyond the current outflow tract. And if we're able to keep this frame within the size of the currently implanted Harmony, once that first Harmony goes in, there should be no risk to further coronary compression. So thank you for your time. And with that, I'll take any questions.
Thank you so much, Dr. Kurtz. If you all could please enter your questions again in the Q&A section. It's in the, if you hover over your screen, it's in the bottom right under Q&A with the little question mark. While we're waiting for people to gather their thoughts, Dr. Kurtz, I had a question. The valves that you mentioned that could be redilated over a patient's lifetime, what are those leaflets made out of, and what's their risk of endocarditis or infection?
Yeah, so unfortunately, I don't think we know the necessary risk of endocarditis and infection yet, as those are still mostly in testing. I believe the first Iris valve, their goal is to implant in 2026. So it's not fully there. The polyvascular valve, I believe, is the one that is a microfiber. And so it's not actually a bioprosthetic material like the other valves are. So that's why the thought of it having better functioning across a range of sizes compared to the bioprosthetic valves, which are native tissue, maybe not human tissue, that once they if they're not able to fully open, or once they pass their normal expansion, they don't function as well.
We have a question that asks, can you review the efforts at improving tissue valve durability?
Unfortunately, I'll be the first to admit I'm not sure, what efforts those are, or how that would work. I think from my knowledge, again, that there really haven't been too much changes in the way we've worked with at least the Harmony and Melody and Sapien valves, being bovine, either pericardium or jugular vein grafts. And yeah, the limitation is that you're probably talking about 10 to 15 years of functioning.
Dr. Kurtz, something I wanted to ask you was some of these valves, particularly the newer ones, how do you figure out what type of valve might be best for a patient? Are there any newer technologies that can help model what valve might fit a patient's anatomy best?
Yeah, so I think some of those questions, some of that is based on implanter preference. I think a lot of these outflow tracts, it could just be, it could fit a number of these valves. And so some of that decision is implanter preference. I do think as we've had increasing use of VR, and especially the companies themselves, so Medtronic and Edwards, do a great job with their screening reports giving virtual implants for the self-expanding valves. And that does really help give the implanter an idea of how it will fit into the anatomy and what it will look like afterwards. And I think that really does give a lot of the decision, especially based on the height of some of these valves, in these patients who've also had branch pulmonary artery work. And so trying to protect the branch pulmonary arteries and encourage and allow access to those in the future. And then I think one of the biggest things really is as we learn more about the ability to valve and valve these self-expanding valves, I think that will encourage us more to probably lean towards using self-expanding valves, even in some outflow tracts that may fit a balloon expandable valve, just because of that ability to place further valves in the future. Apparently, Medtronic is even trying to get an indication for the use of the Harmony valve in RV to PA conduits. I'm a little skeptical of that, but it does seem that as we get more experience with this, unlike TAVR valves, where not that I have a lot of experience, but I've heard from some friends that really your first TAVR valve, you want to be a balloon expandable, and then they might, a valve, self-expanding or really valve and valve only. It sounds like it may be the opposite in the pulmonary position.
I see. There's another question that asks, what are the diameters of a swine valve?
Yeah. So, again, for the most part, the transcatheter valves, though I do Harmony, now that I say that, Harmony may be porcine, not bovine, but they vary again based on company. We're talking the transcatheter valves. You're right. Harmony comes in the TPV 22 and 25 now. So that's the internal diameter of the valve itself. That being said, it can fit outflow tracts larger. The Melody valve comes in delivery systems of 1822, 1820 and 22. So again, that's the internal diameter. And then the Sapien valve comes 23, 26, 29, though that's actually the external diameter. And so the actual valve diameter is probably 1.5 millimeters to 2 millimeters smaller than that.
Thank you. Can you explain how the geometry works to allow up to 8 layers of valve and valve?
Yeah, and so I had wished they had published their pictures already, so I tried to get that to show you, and it was really cool to see it. So basically, what they do is they'll look at the valve on FOSS, and so you can see the internal diameter. And here, let me see if I can share this again to kind of bring up the picture. So can I go back slides? There we go. Whoops. So this valve here, this is the TPV 25 Melody valve, which they were using. And as you can see, the hourglass shape of it is here. And so they were looking at the basically the outer diameter of the larger portion here on FOSS. And as they were placing more Melody valves inside, right, they're placing it here in the kind of waist portion, and measuring the actual footprint of the valve from this outer portion, because that's really what's holding up against the wall of the vessel itself of the native heart. And so they were able to make it so they never actually expanded beyond this outer portion here, so that you kind of almost, you didn't have a reverse hourglass with kind of the apple shape in the middle, yet still maintained the inner diameter of the Melody valve. So the outer Melody valves just kept expanding and expanding and expanding, which the valve can do just fine. Now it won't function that way, but the inner Melody valve, the most inner, still held its inner diameter of about 22 millimeters, and therefore had its as large an opening diameter as it will maintain, and maintains good valve function.
Thank you so much, Dr. Kurtz, for your expertise and sharing your knowledge with us.